So, I'm Dr. Sehrish Abrar. I am a consultant radiation oncology, consultant radiation oncologist at Khan University Hospital. Thank you, Asad Yusuf, for giving me opportunity to present on this forum. So, the title of my talk is the change in the practice and learning points from the image-guided radiation therapy. So in 2020, we got two true beam machines, and we got the chance to start working on cone beam CT scans. So I will share my experience, learning experience with you all as a radiation oncologist. So I have no disclosure, conflict of interest to disclose. And the outline of my presentations will be the introduction of image-guided radiation therapy, that why do we need to do image-guided radiation therapy? What is the need of doing it? Then a little bit of literature review, followed by the learning from our own clinical cases, a protocol discussion. I'm not going to discuss the details of all the protocols, but I want to discuss the few key points which we think is more important in everyday practice, followed by the conclusion. So, introduction. I want to say that we all know that when we start doing the radiation planning, it started with the simulation, followed by the planning CT scan, and then the radiation oncologist marked the volumes. They marked the GTV, CTV, and PTV. Then our medical physicists do the precise planning, and then a time comes for the treatment delivery. So, so the need of the IGRT comes when we know that there could be difference in the plan or the actual treatment delivery. So IGRT is a process to reposition the patient on the setup to minimize the errors. In my next slide, you can see that the local control of any tumor. We all know that when we treat the patient with radiation, the local control of the tumor depends upon the multiple factors, like the biology of the disease itself, the dose of the radiation actually which we are delivering, and the third thing is the method of delivering radiation. The local control depends on this factor as well. So to cover this factor, we know we need to precisely mark the volume, mark the target volume, followed by the precise radiation planning, and then the third steps come to precise treatment delivery. For the precise treatment delivery, we should deliver an error-free treatment to the patient. The definition of error is actually it's the discrepancy between the intended act and the actual treatment delivery. And what sort of error comes in the treatment delivery? They can be the mechanical uncertainties, the geometrical uncertainties, or the dosimetric uncertainties. The mechanical uncertainties actually they are correlated with the machine, the couch, and the gantry motions, like the couch or the gantry motions or the other parameters of the machine. Then comes the geometrical uncertainties. The geometrical uncertainties are related to the position and the motion of the target. And third is the dosimetric uncertainties. It is actually related to the patient assurance, quality assurance. IGRT, which is image guided radiation therapy, actually deals with the geometrical uncertainties to correct those errors, reposition the patient. And these geometrical uncertainties can be either the interfractional or interfractional. So both the interfractional or intrafractional are the combination of the systemic and the random errors. I want to explain a little bit about the systemic and the random errors. What are the systemic errors and why they can be happen. So the systemic errors are essentially a treatment preparation error, except few of the errors are not happen in the treatment preparation. They happen in the treatment delivery. Um, so majority happens in the treatment preparation. So this error come into the chain during the process of simulation, when we are positioning the patient and when we are targeting the volume, actually when we are delineating the volume, or during the radiation planning process. So this error, if uncorrected, would affect the treatment fraction uniformly, which means that a specific portion of the target area would get missed every day. The random errors are essentially a treatment execution error and varies with the each fraction. So every day the error would be different, would be in different direction. So this error is unpredictable and varies with each fraction. We all know that because of there is no error-free treatment, there is always chance of error happening. So what we do, we added a margin around the CTV in the form of PTV to take these errors into account. So you can see a very good depiction of the random or the systemic errors in this picture. This green, this blue dotted line is actually showing the CTV, and this outside this blue dotted line is the dose envelope around the CTV, the idealized dose which we actually wanted to deliver to the patient. So what happens in the random deviation? You see the CTV is inside this dose, but you can see the different position of the change in the position of the dose around the CTV. But the envelope, it is actually enveloping the CTV throughout. But in the systemic error, what happens? A small chunk of the CTV may miss the desired dose, and this actually happens. This error happens again and again in the form of in any form, which we will discuss in later slides. So here you can see that the random error blurs the cumulative distribution of the dose around the CTV, and the systemic error shifts the cumulative dose distribution around the CTV. So why we miss the target? Because there can be many errors happen during the planning process or during the treatment delivery. They can be the mispositioning. They can be the organ motion in the form of interfraction or interfraction, the change in the shape of the organs. So all of these uncertainties, these are all of these things are the source of uncertainties, and they may result in the absorbed dose in the volume of interest and organ address that do not correspond to the theoretical dose plan, which means that we are going to deliver actually which we are giving radiation to the wrong place. So these errors can be from the setup errors or the organ motion. Here you can see in this box that the interfraction variability could be due to the setup errors or the organ motion, like in the form of patient positioning, in the form of volume changes, and in the form of weight loss. And interfractional variability can be happen in the form of, again, in the setup errors or organ motion, like the patient is discomfort in a particular one fraction, and he or she is constantly moving during the treatment. So that's actually the intrafractional variability. Similarly, they can motion intrafractional variability, like the bowel gas motion, peristalsis, cardiac motion, or the lung motion. So the source of error organ motion are the peristalsis, swallowing, bladder filling, rectum filling. These can be intrafractional or interfractional, and they're actually the random errors. Actually blur the doses around the CTV. The error sources of error target deformation, like the weight loss, weight gain, tumor shrinkage, or tumor growth, they are actually the sources of systemic errors. This is an example of interfractional versus intrafractional. Here you can see that in intrafractional, variation happens within a specific fraction, and here you can see that this is the target area marked, and the organ is outside the target area, and this happens because of the motion of the lung. Uh, that's why the gating
شكرا
was.
اخي ديالي نشوفك ساعة الخير ان شاء الله. شي نهار الا لقيناك ساعة الخير. الله يحفظك.
Can you please mute your mic? Uh, and the interfractional variability is, here you can see in this example, this is the position of the rectum in one treatment fraction, and this is the position of the rectum in another treatment fraction. So this actually, the dilated rectum is actually pushing the target area anteriorly. So how we can manage the errors? There are different ways to manage the errors. So we can do the mid-course replanning. We can set up the protocols. We can use the gating, and most importantly, we need to verify the treatment daily with the help of online and offline image verification. So what are the online and offline online or offline corrections? So I would like to give a little insight of what the online corrections are. These are the strategies referred to the patient is on the treatment couch while the verification is being done before the treatment delivery. The aim is to reduce both the random and the systemic errors and the treatment side and expected magnitude of error may determine the frequency of the online imaging. So like daily online verifications are required on those sites where we are expecting the large daily shifts like the pelvis because of the organ motions like the bladder or the rectum. We need to get the daily online verification, and in thorax like the lung because of the lung motion and the abdomen. The other things where we need the daily online verifications are the treatment where we are dealing with the critical structures like the paraspinal tumors are being treated. So the spinal cord is the critical structures, and we need to get the daily online verification. Intracranial tumors in close proximity to the optic structure. VMAT and SBRT. The offline corrections are in offline strategy images are required before the treatment, and they are matched to the reference image at a later time point, and the correction would be applied to the subsequent sessions. Now, a little bit of literature review and learning from our own cases. So, this was a paper which was published by Chanakli et al. And they actually in this paper talked about the change in the size of the parotid gland, which is picked up with the help of cone beam CT scan. Here you can see that these three images. This is the baseline scan, and these yellow colored contoured area is the parotid, and these are the images taken on the subsequent treatment. So you can see that on subsequent treatment, it's a fact that with the treatment, the size of the parotid glands get shrunk, and the position they move the position of the parotid gland is actually changed during the treatment, especially in the cases of the nasopharyngeal tumors where we actually intend to spread the parotid gland. So this fact is important in head and neck cancers that these parotid glands got shrunk, and they move from lateral to the medial position. So in this paper, they actually said that the median percent volume loss was 21.3%, and there was a medial shift from the midline of 3 to 5 millimeter from lateral to medial side. The Barker et al. Reported the similar value of the median parotid volume loss of 0.6% per day, whereas the Rober et al. Observed a similar rate of shrinkage 0.7% per day for both glands. There was another author, he worked also on the head and neck cancer, especially the nasopharyngeal cancers, and he said that If we kept on treating the patient on a single planning scan, like we don't do a replanning, and we deliver the patient, the whole treatment is being delivered after one-time planning, and we don't consider the replanning midway. So in these cases, the end of the treatment dose of the parotid increased on average by 11.38%, and this dose is actually the increased dose. Now, this is another paper, and this is a paper. This paper was done on the cervical cancer patients who were treated with the IMRT technique, and they particularly talked about the impact of the pelvic organ motion on the dose delivered to the target volume. Uh, to me, what I've extracted from this paper, that the bladder volume is very important. The rectal volume is again important. The bladder volume is very, very important in the cervical cancer patients. So this study was done on the CBCT of 10 patients undergoing the chemoradiation therapy for cervical cancer, and they find a correlation of optimal uterine volume coverage as a function of the bladder filling, particularly in the mid-anterior portion of the uterus. The findings were that the greater variation in the patient were seen in those patients where they were large bladder at the time of the planning. And according to them, the definition of the large bladder is that the urine is filled with more than 300 cc. In these cases, a replanning using image cone beam CT scan with the bladder around 300 cc improved the dosimetric coverage. According to them, if we keep the volume, if they keep the bladder volume up to 300 cc, there are less chances, or there will be a variability in the subsequent treatments. Authors recommend an equal but no more than 300 cc bladder volume at the time of the planning, and a range of variability during treatment that varies between 50 cc below and 150 cc above the planned volume. So according to them, this much variation is allowed during the treatment, but we have to keep the volume of the bladder 300 cc at the time of the planning. So this strategy would reduce the variation in position of the target related to the bladder filling without the need of a replanning. So these are the pictures taken from paper, which was written by Chen et al. And in this picture, you can see that this bladder is excessively filled, and this is actually pushing the uterus posteriorly and superiorly. In contrast,
Sorry, your sound is not clear. Excuse me.
is it clear now?
Yes.
I'm sorry for the inconvenience. Well, here you can see in the picture B and C, the position of the uterus is different as compared to the position in the picture A. The uterus is same, but the position varies because of the difference in the filling of the urinary bladder. This is another paper, and in this paper, the author actually talked about the change in the position of the uterus. Um, uh, the impact, they actually talked about the impact of the organ motion.
From previous slide, your sound is not clear.
Is it clear now? I don't know why it's not clear. Is there a background noise which is disturbing, or my voice is not clear?
Yes, now it is clear, but can you repeat the previous slide again? Because it is from previous slide, there's an issue in your mic.
Okay. This slide or this one? So I can repeat both the slides. So in this paper, the author said that if you keep the volume of the bladder up to 300 cc at the time of the planning, there would be no need of replanning, and they allowed the variation of up to 250 to 450 cc bladder volume at the time of the treatment. You're getting my point? So according to them, if we keep the volume 300 cc at the time of planning, there would be less need of replanning in case of cervical cancer patients, because the change, because if you change if there is a marked change in the volume of the bladder, there will be marked variation in the position of the uterus. That's I'm showing in this picture. This picture A is showing the excessively filled urinary bladder, and this urinary bladder is pushing the uterus posteriorly and superiorly. And in these two images, you can see that the position is different. The uterus is same. The uterus is same. We cannot see the change in the volume of the uterus, but we can see the change in the position of the uterus because of the urinary bladder filling. So this is another paper, and in this paper, the author talked about the change in the position of the uterus, again done on the cervical cancer patient, and they talked about the change in the uterus position with the change in the position of the bladder and the rectum. So I particularly picked up the findings of the rectum mentioned in this paper. So according to them, what they did in this paper, they actually marked the position of the uterus in CBCT of all the patients, and you can see the change in the position of the uterus and in these images. And these changes happened because of the change in the position of the rectum and the bladder. So in this paper, they said that the mean change in the rectum volume was 12.8 cc with a range of 91 to 228 cc. 228 cc is a big number, and this much change in the volume of the rectum can make major difference. So the mean change in the CTV centroid position with the change in the rectal volume. This CTV centroid position is actually the CTV of the center of the this uterus volume. According to them, with the change in the rectal volume, what happens, the CTV move in all the three directions, but majorly in the anterior posterior direction and the superior inferior direction. You can see the range in AP direction 9.4 millimeter to 18.9 millimeter, whereas you can see that the in the supine direction the range is 3.8 into 3.8 to 15.3 millimeter. So this is a big difference. We all need to keep these findings in our mind when we are actually thinking of the PTV. So we need to keep in mind that this much variation can happen. That's why we should follow the bladder and the rectum protocol when we are doing the treatment of pelvic patients, because the most change in the position of the rectum and the bladder can make a marked difference in the dose distribution around the CTV. So in this paper, they said that the 10 cc increase in the rectal volume correspond to a superior shift in CTV centroid position of 0.5 millimeter and a posterior shift of 0.52 millimeter. This is another paper, and again, this paper was also done by doing by contouring the volumes on the cone beam CT scan. So what they did in this paper, they had a baseline planning scan, on which the planning had been done. They contoured the volume, rectum and the prostate on the CBCT of 20 patients, and they copied the plan, the actually baseline plan on the CBCT, and they tried to see the difference in the difference in the doses received by the organs. So there was interfractional rectum volume variation. There was significant interfractional rectal volume variation for some patients. According to this author, V40 less than 35 and was not matched for many patients, and 27% did not meet the criteria of V65 less than 17%. So according to the author, there was large interfractional variation because of the change in the position of the rectum, because of the change in the position of the rectum and the rectum filling. The significant fraction, 27% of the actual treatment would benefit from the uh, adaptive image guided radiotherapy based on the daily ACT images. So they can do the replanning for those patients, or they can strictly follow the bowel preparation protocols. Now, this is an example from our own patient, and here you can see the picture. The issue in this particular patient is the weight loss during the phase 1 of radiation. So we planned the treatment, and we were actually delivering the treatment. During the CPCT, after 2 weeks of the treatment, we find out that this patient is losing his weight. So on CPCT, you can see this blue line, sorry, this red line is actually the PTV which we intend to deliver. But because of the weight loss, here you can see that is specifically the fat is this particular area is not getting the desired dose. It's not getting the dose which actually this area should receive. And here you can see the gap. So this happens because of the weight loss. Similar thing happened here again. Because of the weight loss, you can see the initial volume is this, and because of the weight loss in the patient, some of the target area over here and here is missing. So what we did in both the patients, we did the replanning. So patient may experience a significant weight loss, and modification may impact on the treatment volume, which are no longer representative of a new anatomical situation. Alteration results in the potential dosimetric modification with decrease in the dose to the target or an increase in the dose to the OARs. And this happens, we see this thing in our daily practice. So replanning in these cases is advisable. And the recommended replanning in the cases of the weight loss is it should be done not earlier than 3 weeks. The other example is from a cervical cancer patient. Here you can see that this whole area is the disease part, which is involving the cervix and whole of the vagina.
Excuse me.
Ji.
The voice goes down again.
Sorry?
The voice goes down again.
Is it clear now?
Yes, clear. But I think there's some cut in the wire of the microphone. So when you have some moves, so it gets up and down.
Okay, I think it's happening because of the motion of the mic. Probably this is the reason.
Yeah. Okay.
I'll try to keep it static. Okay, so in my next slide, you can see that there is the disease present in the cervix, and the whole of the vagina is full of the disease. After a few fractions, not after a few fractions, after 3 weeks of treatment, this patient showed the remarkable response. And here you can see that because of the change in because the patient, the disease showed the treatment response, there was a change in the shape of the uterus. In this, there are two findings to pick up. One thing is the bladder filling. The bladder filling is not matched as we did it in the planning. One reason for the changing in the position of uterus is this. And the other reason is the disease showed the response. Once the disease is showing the response in the cervical cancer patients, the uterus changed in position. And that's what happened in this patient. When the uterus changed in position, the more and more small intestine comes in the treatment area. And this patient, we picked up these changes, and this patient actually started having diarrhea. So what we did, we did the replanning in this patient. So the tumor shrinkage leads to the change in the position of CTV and organ at risk. If overlooked, it will lead to a lot of side effects and compromised local control. This is another example. This is a patient. She's 10 years old girl, and she has a vaginal RMS. This whole area is diseased. The whole vagina is full of the disease, and this upper two images are actually the planning CT scan. In this patient, the bladder is overfilled with the urine. You can see it excessively filled with the urine. And this CBCT was taken on the second fraction on the second treatment, the day of treatment. And you can see that the urinary bladder is not as filled as it was filled in the planning CT scan. So the problem happens with the overfilled bladder is it is next to impossible to reproduce the same volume of the bladder in all the fractions, right? So that's why the similar thing happened in this patient, and it was overlooked by our technician. So this yellow area is actually the contoured bladder, and below this contoured area you can see the bladder. The bladder is much below the contoured area. And what happened in this patient, more and more gut came into the target area, and more gut received the excessive radiation. So what we did, we picked it up during the offline image correction, and we advised the replanning. I put this picture, but this is not our patient. I take the resources, not our own patient, but I want to discuss this issue as well. That what happens in the prostate cancer patients, once we do very good planning in the simulation and the CBCT, or when we are doing the planning CT scan. But what happens in the treatment, sometimes the rectums become distended. And you can see this green line is the rectum, and this blue line is showing the prostate, and this this red line is showing the prostate, and this blue line is showing the bladder. And this is the picture taken on the day of treatment. And this green line outside, there's a small circular line. This green line is showing the distended rectum. So what happens when the rectum is distended? In the prostate cancer patients, it actually pushed the target area interiorly. Here you can see this red line is actually the actual position of the prostate on which the planning was done. And because of this distended bladder, this whole prostate was pushed interiorly. So this area would not get radiation. Obviously, this would not get radiation. The pushed area would not get radiation and would be missed in that particular fraction. Again, this picture, these two pictures were not from our real patients, but I want to discuss this issue as well. That what happens in prostate cancer patients, sometimes it happens that. Can you hear me? Can you hear me? Okay. So this happens in the prostate cancer patients, that because of the organ motion during the treatment, the prostate motion itself, it may miss from the target, it may miss from the treatment. So I think in our 2 years of learning from IGRT, especially from the whole beam CT scan, I think it's very pertinent to discuss the importance of the pelvic radiotherapy.
Could you please close your mic to your mouth?
Okay.
I think the mic is far from you.
Okay.
Thank you very much. Sorry for interruption.
No problem. No problem. So I think it's very important to discuss the patient education in clinic about the pelvic radiotherapy. That's why I put few of the slides. Um, when we discuss when we give the education to the patient in the clinic, we talked about the regular bowel movements, and we advise them to take enough water to hydrate themselves. Our advice actually help them to establish the regular bowel habits and increase the hydration, and that help us to to keep the rectum volume inconsistent in size, and there will be less buildup of the intestinal gas, and the bladder would be inconsistent size during the treatment. So we advise them to take plenty of water, and we advise them to take at least Abbas, can you hear me now? I don't know what's the issue. Can you hear me? Take it. Okay. So so um so we advise them to take plenty of water. We advise them to take excess of 2 liter water. Keep themselves hydrated, and this excess amount of water will keep themselves hydrated and keep the bowel habits regularly. And we advise them to eat regularly. Don't skip your food. Avoid those foods which cause the bloating, like the foods. Some of the foods make more gases in the intestine. We ask them to avoid those gases before the planning CT scan and during the treatment as well. And we advise them to do regular walk, and some sort of exercise help the intestine to mobilize and to become more and more mobile, and and to win out the excess gases in the intestine. And we advise them to avoid swallowing air when you eat, and the some of the laxatives, we ask them that some of the laxatives, if you're using, to stop them, because the laxatives, those laxatives which are made up of sugars, they actually form gases in the intestine. On the day of the planning scan, we advise them to take a light breakfast, and they are being advised to drink fluids. And before the planning scan, we ask them to defecate and pass the urine, and then we give 500 ml of water to them, and we wait for 20 minutes, and then we take them on the machine, and we take a small scano scan of particularly the pelvic area, to see the bladder position, is it adequately filled or not. There is particular definition of adequate filled bladder, which I'll discuss in the later slides. And then and if it is not adequately filled, we ask them to wait for 10 more minutes, and then we take them again on the machine. Sometimes it happens if the rectum is too full or the bladder is not full enough. We ask them to do the scan on the next day, and we advise them. And we give them advice what sort of problem, like if the patient is having the distended rectum, we give them medicines to properly defecate, and we ask them to take more and more water and to walk, and all these things are being advised. On the day of treatment, we ask them to eat normally before your treatment, and drink all the required amount of water as instructed within the first 10 minutes, and then the remaining time allow your bladder to fill to the same size as for your planning CT scan. So the issue of rectum and bladder filling is the rectum preparation and the bladder filling is very important in the pelvic cancer patients. And here you can see these are the treatments. These are pictures. Picture A is actually the treatment pictures, and the treatment B is the simulation pictures. Here you can see that the rectum is not filled, and it was about 4 centimeter in diameter. So we planned the treatment on these scans. But on treatment, the patient did not follow the advice, and here you can see the distended rectum. It is full of the air and the stool. Now I will discuss what is definition of the adequate bladder filling. So this is one way to quantify the bladder volume. What you can do, you can on the coronal image, you can draw a line, or you can bring the scan at the level of the femoral head, just above the femoral head, like we did in this picture. This blue line is showing it's just above the femoral head. Then you will go to the you will go to the sagittal axis, and you will follow the same line, the same blue line, and you will measure the distance from this blue line to the dome of the bladder, and you will see that how much centimeter is filled with the urinary bladder. Now, I'm showing you the example. This is an example of the overfilled bladder. The first example is the overfilled bladder. We keep the x-axis at the level of the femoral head, just above the level of the femoral head, and here we measure the distance between the dome and this blue line. This is more than 4 centimeter. If this distance is more than 4 centimeter, that means it is overfilled bladder. You should ask the patient to pass the urine, give the water again, and wait for 20 minutes, and then take the patient on the machine. This is the example of the adequately filled bladder. So again, the same reference point. If this line is in between 2 to 4 centimeter, that means that the urinary bladder is adequately filled. And the third example is the underfilled urinary bladder. If this distance is less than 2 centimeter, that means that the urinary bladder is underfilled. You will get the more understanding from this picture. This is an example of the underfilled bladder when this distance is less than 2 centimeter from this blue line. When it is in between 2 to 4 centimeter, it is adequately filled. An average 3 centimeter corresponds to the 300 ml. You can take the reference of this 300 ml from the study which I discussed a few slides back. And if it is more than 4 centimeter, it means that it is overfilled bladder. So in conclusion, IGRT allows us to correct for the setup errors, as well as both in the form of the interfraction organ motion or the interfraction organ motion. It allows us the high resolution, is actually the high resolution image guided radiation has become a mainstay of the modern radiation therapy. We cannot do the VMAT, or we cannot do the stereotactic radiation without IGRT. IGRT has widened the therapeutic window. It helps us to improve the local control by delivering the precise treatment to the patient. And one more thing is that MV X-ray alone, MV X-ray portal films alone cannot detect the changes which we have discussed and we picked up on the cone beam CT scan. So to pick up all these changes, the cone beam CT scan is mandatory. And to quantify the cone beam CT scan is actually quantify the intra or the intrafractional internal organ motion. Thank you for listening. Okay. So let me see the chat box. You said one plan for a patient, but sometimes you need to make two adaptive plan. What's your opinion? Um, yes, like adaptive RT, there are two things in the adaptive radiation. One thing is that um, the evidence of this thing which I am discussing now is not very strong. That you decrease the volume, you decrease the volume. For example, if there is a cervical esophagus patient is getting radiation, and the disease responded very well, is responding very well to the radiation, and after like 20 treatments you don't see the disease. The evidence of this thing that shrinks the volume, the PTV or the CTV, it's not I don't think so it's good practice. And I think doing this kind of practice you need a very strong backup, very strong team. You need very strong you know the skills of the RTTs should be very strong. So I don't think so to make the CTV smaller is a good practice. But in the cases where, like the cases which we experience every other day in the head and neck cancer patients, because of the weight loss of the patients, the anatomy of the patients got changed. So in these cases, we do plan once or sometimes twice. So the twice planning, I don't see it frequently, but yes, once replanning we see it frequently.
Okay, any other question? Oh, there's another question. Could you please, for prostate cancer, majority of motion of prostate is in anterior or posterior, or in superior or inferior?
So in prostate cancer patients, again, it depends upon the. I haven't come across any study. There must be studies like that, but I haven't read up any of such a study where we can, on the basis of which I can tell you that. What sort of or what exact difference we can see in the prostate cancer patients in different direction. But what my observation is, the impact of the rectum filling is more on the prostate cancer patients as compared to the bladder filling, the difference in the bladder filling. So what happens that if there would be, it again depends upon the difference in the rectum filling, depends upon the rectum difference in the rectum filling. If there would be more, or there would be excess air or the stool in the rectum, so that distended rectum would push the prostate, the target area, in anterior posterior direction. So I think the more disruption happens with the change in the rectum volume, and particularly in anterior posterior direction. Any other question? Okay. It's not. If it's not good, what you suggest should be skipped. If it is skip, so it's. Acetylcholine for empty bladder, as you outlined. Yes, the thumb of rule is for the rectum particularly. The thumb of rule is you should accept the 4 centimeter diameter of the rectum. If it is more than that, you should not accept it at the time of the planning CT scan. Okay, I guess I missed that. What's your recommendation about the typical margins of CTV at cervix? Okay, so let me go back to the slide. So we were actually talking about the shifts in the cervical cancer patients because of the rectum filling. In this paper, they particularly said that because of the rectum filling, the major difference come in the anterior posterior direction and the superior inferior direction. And I hope I answered your question.
Okay, in the interest of time, we'll move on.